non-communicable diseases and injuries, Closing the Gap for the Poorest Billion global event, organized by the Lancet NCDI Poverty Commission. I am Chelsea Clinton, Vice Chair of the Clinton Foundation and a Lancet NCDI Poverty Commissioner, and I have the great honor of serving as the Master of Ceremonies today. It is a real pleasure to be among so many distinguished guests. This is a first of its kind virtual event that aims to spark a new movement around one of the world's greatest and yet most often overlooked health disparities, NCDIs that kill and disable millions of people every year in the poorest countries on earth. I want to thank you for joining us, as this is the time to act on behalf of the poorest people with whom we share our planet. Before we begin, we would like to recognize Dr. Bongani Mayosi, a hero, a leader, and a fellow NCDI Poverty Commissioner who worked tirelessly on this report and passed away before its completion. I want to thank him for his service to the cardiology community in Africa and his real leadership and contributions to the fields of medicine and global health. And we want to dedicate this report to him. It is now my pleasure to welcome Lancet NCDI Poverty Commission co-chairs, Dr. Jean Buckman and Dr. Anna Makombi, and the Lancet editor-in-chief and publisher, Dr. Richard Horton, to discuss this landmark NCDI poverty report, the intersection of NCDIs with COVID-19, and the way forward.
My name is Anna Makombi, and I'm based at Universidade Eduardo Mondlane and Instituto Nacional de Saúde in Mozambique. On behalf of the Lancet Commission on Reframing Non-Communicable Disease and Injury for the Poorest Billion, including my commission co-chair, Jean Buckman, thank you to everyone for joining. Jean and I first met and our friendship began 13 years ago at a conference in Nairobi, which Bongani Mayosi had organized. It's amazing to think that Bongani was only 38 years old at the time, and already an inspiration to so many. Jean was traveling from rural Rwanda, and I was coming from Mozambique. We were both cardiologists treating patients suffering from fatal and debilitating diseases. Most of these patients were children and young adults with conditions like rheumatic heart disease that had virtually ceased to be a problem in rich countries, but were a death sentence in poor places like in rural Africa. Because these diseases were not considered to be the foremost killers, either in developed or developing countries, our patients' suffering was nearly invisible. Bongani was trying to build a movement to change that. At that time, the United Nations system was rallying around the Millennium Development Goals. These goals prioritized the major causes of maternal and early childhood death, as well as big infectious diseases like HIV, tuberculosis, and malaria as the primary health challenges facing the world's poorest people. Set aside for another time were the terrible non-communicable diseases and injuries we were seeing. Conditions such as type 1 diabetes, rheumatic heart disease, asthma, pediatric cancers, epilepsy, severe mental illness, congenital hydrocephalus, burns, and physical trauma, to name just a few. In the coming years, Jean and I watched with hope as a new global movement on non-communicable diseases took shape. We were then saddened when this movement focused almost entirely on prevention of behavioral and metabolic risk factors for a limited set of diseases that had been the major killers of all the adults in rich countries, diseases such as coronary heart disease and stroke. We feared that this movement was failing to account for the diversity and severity of non-communicable disease and injuries among the world's poorest people, whose greatest risk of death comes from poverty itself, including lack of access to quality health care. We also feared that this movement was not calling strongly enough for the global funding needed to solve this problem. Based on our personal experiences and those of our colleagues around the world, Jean and I suspected that the burden of non-communicable disease and injury among the poorest was far more compelling than previously acknowledged. It was not until the Lancet, under the leadership of Dr. Richard Horton, accepted our proposal to initiate this project, and we received the generous financial backing of the Emsley Charitable Trust, that we were able to gather the data to prove it. The important findings we are presenting today come from a global commission of experts as well as hundreds of other contributors. This is an amazing group of colleagues who have been working together for 5 years to produce the clearest picture yet of the problem we have called NCDI poverty and the solution needed to address it. This work has also been informed by national NCDI poverty commissions in 16 low and low middle income countries where more than half of the world's poorest people live. These national commissions involved more than 250 of the world's poorest people, of the world's leading government officials, academics, and practitioners focused on NCDIs. 7 of these national commissions have already published and launched their initial reports and are helping their countries prioritize the needs of the poorest for the NCDI response. We also listened directly to the voices of people, especially young people, with lived experiences, and have collected and preserved their stories through video interview. You will hearing from some of them shortly. Of course, we didn't expect to be launching our work in the middle of a pandemic. COVID-19 has revealed that the agenda we have laid out is more urgent than ever. As we say in our report, quote, "This commission tells the story of endemic diseases among the world's poorest population, for whom NCDIs are part of the nexus of infection and hunger, mitigated, we hope, by life-saving technologies, policies, and social protection. The embodiment of extreme poverty in diseases such as tuberculosis, malaria, and childhood infection is well documented. But in the case of NCDIs, there is a need to recognize that they too are part of the unfinished health agenda for the poorest."
Thank you, Anna. My name is Gene Bookman, and I'm based at Harvard Medical School, Brigham and Women's Hospital, and Partners in Health in Boston, Massachusetts. Thank you also to Chelsea and to all of you. This commission created working groups focused on understanding 4 key issues. First, the nature of the burden. Second, what can be done about it. Third, how to finance solutions. And fourth, how to integrate non-communicable diseases and injuries of poverty into global health governance. As a commission, our first task was to identify who the world's poorest people are and where they live. In order to do this, we worked with researchers from the Oxford Poverty and Human Development Initiative to aggregate and analyze microdata from more than 100 nationally representative household surveys from low and middle income countries. As a global community, we spent the last decade thinking extreme poverty would become a thing of the past. But we found that extreme poverty has not gone away. And in the wake of the COVID-19 epidemic, the World Bank predicts that extreme poverty will in fact rise. The poorest billion people have an existence that has been described as beneath any reasonable standard of human decency. We found that fully 90% of this population lives in rural areas of sub-Saharan Africa and South Asia, although there are still pockets of extreme poverty everywhere. Around 2/3 are dependent on agriculture for their survival. And as you can see from the dark red on this map, the concentration of this poverty is highest in many of the sub-Saharan African countries. Importantly, we found that this is an incredibly young population. 80% were younger than the age of 40. What we will show you next are the results of our work to quantify the magnitude of the NCDI burden among the poorest billion. As Anna mentioned, we call this burden NCDI poverty. In order to arrive at our conclusions about the nature of this burden, we combined socioeconomic microdata from household surveys with national estimates of disease rates. We also conducted literature reviews and analyzed primary data from health and demographic surveillance sites and conducted expert surveys to assess the direction and strength of the relationship between NCDIs and poverty. When the Commission began to analyze the burden of disease among the poorest billion, we learned that the global community had bought into a number of dangerous myths. The first of these myths was that non-communicable diseases and injuries are not currently a significant problem for the poorest. In other words, that these were emerging issues that would come only in the future, along with development, aging, and urbanization. In fact, the data paint a different picture. This slide shows our findings regarding the quantified magnitude of death and suffering due to NCDIs among the world's poorest billion people. This figure also compares the NCDI poverty burden with all the infectious maternal and childhood nutritional conditions prioritized in the Millennium Development Goals. The dotted lines show the burden just among the poorest billion. In the next slide, we show the magnitude of the burden addressed by the global NCD agenda put forward by the World Health Organization between 2011 and 2018. This agenda was known as 4x4, or 4 diseases and 4 risk factors. It focused largely on adult cardiovascular diseases, cancers, lung diseases, and diabetes that were driven by tobacco, alcohol, unhealthy diets, and lack of physical activity. As you can see, we found that in contrast to the Millennium Development Goal agenda, most of the death and suffering addressed by 4x4 was concentrated outside of the world's poorest billion people. We also found that this agenda failed to address around 2/3 of the NCDI poverty burden. It's important to remember that our interpretation of 4x4 here is very generous because we were actually including all of the cardiovascular diseases, cancers, lung diseases, and diabetes, not just those caused by so-called lifestyle risk factors. Fortunately, after much global advocacy from our commission and many others, in 2018, the United Nations added mental and substance abuse disorders, as well as air pollution, to its definition of NCDs within a 5x5 framework. And increasingly, prevention of road traffic injuries has been recognized as an important priority. In the next slide, we show how much of the NCDI poverty burden is still left unaddressed by existing global frameworks. We found that even after including these important issues, existing frameworks fail to address more than half of what we've identified as NCDI poverty. And the part of the NCDI poverty burden that is being most neglected is the roughly 50% of the burden that falls on those under the age of 40. We found that approximately 70% of the NCDI poverty burden among those under 40 falls outside of these established global priorities. In fact, we have found that among the poorest billion people, non-communicable diseases and injuries claim nearly 800,000 lives before the age of 40 every year, more than HIV, tuberculosis, and maternal conditions combined. Many of us on the commission are practicing physicians. Like all doctors, we want to do what is best for our patients, and we are outraged when solutions are available but out of reach. Yet for too many people, that is the reality. The commission found that a majority of years of life lost to non-communicable diseases and injuries among the poorest billion people is avoidable through treatment and/or prevention when compared with rates in high-income countries. As you can see in this slide, this avoidable burden is due to a wide range of non-communicable diseases and injuries. The fraction of the NCDI poverty burden that is avoidable is particularly high among children. You can see this most clearly by looking at the disparity in the loss of healthy life among the poorest billion who acquire non-communicable conditions compared with the loss among those with these conditions in high-income countries. The gap can be as great as 20 years of life lost. This health loss transition is particularly striking for diseases like type 1 diabetes, which can be routinely managed in rich countries, but are virtually a death sentence for the poor, or for surgically correctable conditions such as congenital heart disease, or, for example, for treatable cancers in childhood. These obscene inequalities are growing amid COVID-19 for multiple reasons. People with underlying health conditions such as non-communicable diseases may be more susceptible to severe COVID-19 illness. At the same time, economic lockdowns during the pandemic have made it challenging, if not impossible, for many poor people with severe chronic diseases to receive essential care. Perhaps most importantly, the COVID epidemic is challenging for efforts to expand health services for NCDIs in the poorest countries. Despite the prior decade of massive global economic expansion, most of those people experiencing the double burden of extreme poverty and severe NCDIs are getting no treatment at all. We have to do better than that.
Jean mentioned myths. Another myth the Commission wants to overturn is that there is not much that can be done to alleviate the suffering of non-communicable disease and injury among the poorest billion people, and that if anything is to be done, it should be focused on prevention and on very limited set of services delivered in primary care settings. In fact, there is much that can be done to reduce non-communicable disease and injury amongst the poorest. Working with Disease Control Priorities Project, The Commission identified no fewer than 183 interventions for NCDIs just within the health sector. In addition to important intersectoral policies, these interventions include a wide array of surgical, medical, psychosocial, and rehabilitative services with demonstrated impact in real-world conditions. When you ask national experts which of these interventions they would prioritize to fight non-communicable disease and injury among the poor, you get very different answers than if you just read global action plans. Look at the left. These are interventions identified globally as the best buyers for non-communicable diseases. They focus primarily on prevention of unhealthy behavior and a limited number of primary care interventions focused on management of cardiometabolic risk and prevention of cervical cancer. Now look at the right. These are interventions identified by national experts in countries where the poorest billion people live. National experts prioritize a greater variety of interventions at multiple levels of the health system, referral centers, district hospitals, health centers, as well as in the community. For the national experts, prevention is vitally important, but so are treatment and care. I know what you may be thinking, because Jean and I have heard it before. How do you practically implement this agenda, especially when there is such a diverse burden of disease and it's not feasible to scale up programs for each disease individually? The Commission proposes the concept of integrating care teams that cluster trained health providers and essential equipment around shared competencies. We think this can be a breakthrough for moving forward. Many donors are beginning to invest in promising pilot projects, including those that follow the World Health Organization's PAN Plus and PAN packages of interventions. There is now an opportunity for countries to bring these projects to scale by integrating them in systematic health reforms.
Thank you, Anna. There are two more myths the Commission uncovered that I hope you will all join us in dispelling today. It is widely believed, in fact, it is written into some global plans, that development assistance for health over the past 2 decades has largely met the needs of the poor. And in the era of the Sustainable Development Goals, low and middle income countries can finance the response to non-communicable diseases and injuries entirely themselves. We have found that this assumption is manifestly false, even assuming the most optimistic future projections. Here we show our estimates of available funding for health in low-income countries, including current levels of development assistance. Even when we assume 6% annual economic growth, high levels of domestic revenue collection, high levels of government budget allocation to health, the available resources to finance universal health coverage by 2030 remain below $50 per capita, far less than the $84 per capita needed by some estimates, and shockingly below the thousands of dollars spent per year per person in high-income countries. What is most remarkable is that by far the greatest gap in financing for universal health coverage in these countries is non-communicable disease and injuries. And this was the situation before the COVID-19 epidemic. The lack of recognition of this fact about the nature of health financing in the poorest countries has led the way to a final myth. The prevention-focused global NCD strategy that has been pursued since 2011 is somehow going to dramatically benefit the world's poorest people. In fact, we have found that the NCD development assistance for health over the past decade has remained almost non-existent and has largely moved away from the countries where the poorest people live. And this has happened during a decade of tremendous global economic expansion. This is in contrast with the funding for HIV, maternal health and malaria, for example, which grew during the Millennium Development Goal decade and has been largely focused on the poorest countries. Of total development assistance for health, the Commission finds just 0.3% goes to the non-communicable diseases and injuries of the poorest billion people. You are here to help us bring about change. We are pleased to announce that an NCDI poverty network is being formed to help implement the recommendations of this Commission, namely, to broaden the NCD and universal health coverage agendas to address the diversity and severity of the NCDI burden among the world's poorest billion people. This network will work through new and existing national NCDI poverty commissions to support countries through a 4-stage process leading to national financing and implementation of integrated care teams and systematic reforms to improve the quality of healthcare delivery over the next decade. The network will also work to raise the funding needed to fill the gap in resources. The network can't succeed without your involvement, and we hope you will join us. Like Anna, I got involved in this cause because of what I saw with my own eyes and in my own patients, and what I knew the rest of the world was failing to see. COVID-19 has challenged us all to do better, and fighting non-communicable disease and injuries among the poorest billion must be part of that agenda. Thank you all.
Well, let me congratulate Jean and Anna and all the commissioners for really what is a spectacular piece of work. 5 years it's taken to put this together, and I'm extremely grateful. My name is Richard Horton, and I work here at the Lancet, which has the privilege of publishing this superb commission. I too would like to underline my tribute to Bongani Mayozi, who died 2 years ago. As the commission notes, he was our inspiration, he was our friend, our colleague, and our mentor, and we miss him dearly. Many organizations contributed to this commission, but I would also like to thank the Helmsley Charitable Trust. Without their support through the whole 5 years, we would not have been able to complete this piece of work. Now, as both Anna and Jean noted, we are publishing this commission in the middle of a pandemic, which will soon have taken the lives of 1 million of our fellow citizens on this planet. The figure as of today reported by the World Health Organization is 925,965 deaths from COVID-19. This coronavirus is one that exploits and accentuates divisions and inequalities in our societies. It's a virus that targets the most vulnerable people around us. Seniors, Black, Asian, people of color, key workers, for example, in healthcare, in schools and education, in transportation systems, in delivering food, keeping our supermarkets open, and of course, people living with chronic non-communicable diseases. We are seeing that COVID-19, as do all pandemics, strikes the poorest people hardest. And here we have a terrifying intersection of forces, a syndemic, a combination of three concurrent epidemics. An epidemic that is COVID-19, the epidemic of non-communicable diseases, and an epidemic of inequality, disparities within countries and between countries. Now, many, perhaps one might even conclude most governments, have failed dismally to act decisively to protect their citizens from the lethal effects of this pandemic. Even countries that had the resources to act, such as my country, the United Kingdom, or the United States, have failed to do so, with the result that tens of thousands of people have died needlessly. These political failures mean that today our world is sitting on the edge of a precipice. The pandemic continues to challenge us on every continent, in every community. And as the economic crisis that has following this pandemic deepens, each nation is going to have to plan for national revival and regeneration. A key part of that plan must be to protect the health and well-being of their citizens. And this commission sets out the necessary steps to address a crucial part of the syndemic, a syndemic that is gradually eroding our societies and our security, our prospects and our hopes. Now, if you read this commission, you will see that it is a very serious document, full of new data, new analyses, and original proposals. But it actually has a very simple, a very clear, and a very optimistic message that should be embraced by political leaders and policymakers alike. And that is that we have now brought together the knowledge to save millions of lives amongst the poorest of those with whom we share this fragile planet. And our task today is to begin to plan how we do so. I would now like to introduce a video that will tell you stories from those who are living with NCDI poverty. So let's see the video now.
हजुर मेरो चाहिँ इटरीमा थाहा भएको हो त्यति बेला चाहिँ म चाहिँ एकचोटी चाहिँ म बिहोस पनि भए हो मेरो बाबुको लागि उपचार नै गर्न खोज्छ
Après ça, je venais à tout ça, toujours, depuis me font manger, et toujours monter. Par rapport à moyen, nous devons pas faire régime, et puis nous tout continuer à manger. Après ça, anémie, tu viens laguer matin, tu viens bas, et puis au bon sang, au bon ménès, et puis après ça, je devons venir, et puis je devons joindre un proche, et puis je viens entrer dans le programme, et puis je toujours besoin de médicaments, et puis je toujours aller dans. Insuline, c'est quand je mets dans le frigidaire. Et puis chaque matin, je prends un moi par rapport capable de tout finir avec moi. Et ça fait une difficulté avec.
Ndithakusiyanitsa ifwa malungo munthu matulwala ndikupeza kobwino pamene vuto la iyeyu ndilotenga nthawi
kuti ndikapanga vinthu yolakwika kapena kutani sindinkadziwa ndikangoti ndikachita mantha thumazi nkangondimenya kuti taimene ndikatero basi ndikinyamuke kuyamba kuthamanga nthawi imeneyo wina lese amandiwopa chifukwa wina lese panafika point yoti ndiphedwe koma mphamvu kuthamangira kuchipatala.
Koma nali ndi vuto pa mtima pabwino nalionongeka ndiye achipatala ndi aboma apo ndithandiza ananditumiza ndiye kufikira panopa ndimapitabe kuchipatala mwezi uliwonse amakandibaya jekiseni zikhala ngati pa mtimapo vuto lipanga operation ipo basi masiku enawo ndimatha kugwira ntchito bwinobwino.
पहिला त एउटा बिग्रेको थियो भने पछि अब अपरेसन गर्नुपर्छ भने अपरेसन नगरी यहाँ आएँ अनि अपरेसन नगरेर घर आयो अनि अब आर्थिक पैसा नि थिएन जाँदा अनि पछि अब दुईटै भल बिग्रेर एउटा अलि बिग्रिन आँट्यो रहेछ.
Ineyo sindinkadziwa kuti munthu kumene nditangothamangira kuchipatala ndapezeka kuti osikhaso mavuto noti kapena kuti ena amandipikira kuti ayi kugwirana ameneyo ayi panopo ndithu amatichula aphiri.
कसैको त अब हुँदै हुँदैन कसैको त अब के बालबच्चाको लागि त नहुनेलाई त अब हेरिराख्नु पनि भएन अब ऋण काटेर पनि गरिन्छ त्यसले पछि कसरी तिरोस् है त्यस्तो चाहिँ नहोस् के यो रोगको लागि चाहिँ त्यसै पनि गरेर तिर्ने चाहिँ उयो छ.
Thank you very much indeed for that video. And now we've got some time to have a discussion with Jean and with Anna about the implications of the Commission. Hey, well done. It's great to see you. And you must be mighty relieved to have delivered this fantastic piece of work at long last. It's really an incredible achievement. But we have to face the fact that we're living in difficult times. And what I'd like to do is to ask you what steps we now need to take. The whole world is talking about nothing but COVID-19. And it's very, very hard to get any other issue on the international agenda. So Anna and Jean, what are the next steps that you'd like to see us do to really make sure that the crucial messages in this commission are listened to by policymakers? How do we get our message heard? So let's start with you, Anna.
Thank you, Richard. We did not think of COVID, but we were well aware that the world's state was not that of receiving even one more burden, such as the need to create movement and to fight non-communicable disease and injuries of poverty. We then, in our work over the years and with the help of the other commissioners, thought of creating a network of NCD, a network that we were able to make function and is now very live. A network joins several countries among the poorest, which are to the light some activities and some of our proposals. We have an that can be done with little, as this network already started working, and 1 month after COVID, we had several efforts, and with very little funding for each of the very big state of mind and heartful activities, we have been able to all together try to show that a lot can be done here in new models, very different from one country to the other, but models that helped us to reach out to people and CDIs, particularly chronic patients already diagnosed, that we could follow. So that this network will be fundamental in doing this, along with the national commissions.
Yeah, I mean, Jean, the national commissions have been almost a proof of concept study, haven't they?
Yeah, I mean, I think that, over this past 5 years, one of the most amazing things that happened was these national commissions. And we mentioned briefly that, at this point, 8 of them have already published their reports. Their structure really mirrors the structure of the Global Lancet Commission. I should say that the Tanzania National NCDI Poverty Commission is launching its report today. And they really are the future of what we're doing the next decade. We've issued requests for interest for new countries to join the network. And within the network, we've actually issued requests for interest to initiate what's been called the PEN Plus strategy together with WHO, particularly in the African region, to really prioritize some of the more severe chronic NCDs in the response to COVID, actually, in terms of decentralizing care when tertiary referral facilities are becoming less accessible. But I think the other thing that we've learned in the course of the commission is just how remarkable it was that in the past decade, as we say, of just tremendous economic growth, that the resources were not there to begin to address this problem. And it's really, I think, shown, and many things that COVID's revealed, that I'm not sure that the resources were ever really the issue. And that it seems to me that there's a fundamental sense of the narrative that we were basically done with the health agenda for the poorest people at the beginning of the last decade, and we had somehow moved on from that. A part of the story that we were, telling with NCDs was very consistent with that. So I think that I'm actually very optimistic that in recasting the story and drawing attention to this population again in the context of COVID, that we may be able to capture the kind of energy that we saw in the HIV movement, the global solidarity that people with common diseases share, and maybe form new kinds of coalitions. COVID has really, I think, called into question a lot of the categories that we were working with, and there may be new kinds of categories that emerge. So I'm actually, I don't see this as a huge change to our fundamentals.
And of course, it's no accident that we're launching this at the same time as the United Nations General Assembly. We want this to be complementary to the work that's been achieved and succeeded with getting NCDs on the SDG agenda, but now we want to broaden that. But I want to ask you one more question, both of you, before we go to the next segment, and that is, I alluded to it in my opening remarks. We are facing this deep economic crisis now that is going to sweep the world. And so resources are going to be even less available than they were before. How are we going to navigate our way through this global economic catastrophe, calamity that we are facing? Because that is going to be a huge additional challenge to the health of the poorest people on our planet today. Anna.
Thank you, Richard. I think that we see an opportunity, and like Jean, I'm optimistic. I think that the message that we wanted at the end of this commission was really to show that more than lack of money, there was also lack of solidarity, led by the understanding of the urgency and the relevance of the NCDI poverty problem. Our commission and our there to show this and to allow everyone in the world to put hands together and fight this calamity. So we think that even with the challenge of COVID, have to find ways, and one that we think will be very important is joining our efforts to streams. We think of, and we talk about this in the report, we think of integrated care with integrated care teams and shared competencies, and we think of integration of care and sciences. And science, we think that increasing the knowledge about the problem, making these diseases not more neglected than they are, rather investing on knowing more and improving the knowledge about them will be good for it, and it's in fact a matter of justice and equity.
Beautifully said. Jean, briefly.
I couldn't agree with Anna more, and I think that basically we need to find new ways of raising money. I mean, I think that the United Nations system and bilateral relations weren't able to raise money for this when there wasn't an economic crisis, and I think that I'm still hopeful that we can leverage people's shared humanity to act on this, especially if we work together in the way that Anna described. And I think we'll hear more about that today.
Thanks very much. Well, I want to hand over to the next segment on how do we change business as usual. But I want to say that this is actually the beginning of a project, not the end. This publication marks our commitment at the Lancet to continue to work with both Anna and Jean and the commissioners on this quest to get non-communicable diseases and injuries and poverty much, much higher on the global political agenda. So in solidarity with the team, let me hand over to the next segment. And thank you all for tuning in.
Thank you, Dr. Buckman, Dr. McCombie, and Dr. Horton for that fascinating conversation. I would now like to introduce our first panel on NCDI's Changing Business as Usual that will be chaired by Lancet NCDI Poverty Commissioner, Dr. Agnès Benawahu.
Oh, I live in Rwanda, where I am now. I lead the University of Global Health Equity, and I was privileged to work during 5 years with the fantastic team that the two co-chairs have presented to you. As shown in the Voice of Poverty video, the world poorest billion suffer from severe conditions nearly invisible to policymakers and funders. And despite their effectiveness, intervention for NCDI or for poverty-linked diseases have generally been overlooked in favor of more limited set of interventions, such as reducing behavioral risk factors, unhealthy diet, lack of physical activity, tobacco, the harmfulness of alcohol, etc. However, we know that NCDs are linked to social determinants of health and to poverty. The best way to improve the life of people living with NCDs is to promote universal health coverage so that they can access treatment and also to support programs to escape poverty. To achieve this mission, we need a more ethical donor community that can improve the expansion and integration of services and empower countries to create integrated health plans. And of course, we need to continue to listen to the voice of people living with NCDs to generate solutions that work best. Dear participants, the coming panel will discuss how do we change business as usual. We are blessed to have with us on this panel 3 exceptional ladies. The first one, Dr. Mweti, is the World Health Organization Regional Director for Africa and the first woman to occupy this position. She was recently confirmed by the WHO Executive Board after her re-election for the second term. Over the past 5 years, Dr. Mweti has led the transformation agenda that is widely acknowledged to have improved the performance and effectiveness of the organization. Dr. Mweti is a medical doctor and a public health expert with more than 40 years of national and international experience. Our second panelist is Dr. Sania Nishtar. Dear panelists, Dr. Sania is the Special Assistant of the Pakistan Prime Minister and Federal Minister, Poverty Alleviation and Social Safety Minister, Government of Pakistan. She is the founder of ISAS, the government's flagship social protection program that leads its implementation. She is the former co-chair of the World Health Organization High-Level Panel Commission on Non-Communicable Diseases. She has funded the NGO Heart-File in Pakistan and has also previously served as a federal minister in the Pakistan government in 2013. Our third panelist is Leia Kilenga Masamo. She is the founder and the CEO of Africa's Sickle Cell Organization. Leia is a Kenyan patient, a global health advocate, working intensively on sickle cell disease and non-communicable disease in rural Kenya and globally. She led the development of the national guidelines for the control and management of the sickle cell disease in Kenya. She has been recognized by His Excellency President Uhuru Kenyatta as the Kenyan hero for her work on sickle cells. Dear Dr. Mweti, I will ask you the first question. As the coronavirus pandemic is overwhelming health systems and divert limited resources, how is WHO working to protect the continuing of care for those suffering from non-communicable disease and injuries? especially in rural poor populations?
So thank you very much, Dr. Binagwaho, for that question. Great question. I'd like to start first by congratulating really the Lancet and the NCDI Poverty Network and the Commission for having done this tremendous amount of work and produced this very important report, which I agree is going to change our way of working to address NCDs and equity and justice and improve our ability to get to the sustainable development goals. So it's going to be central to that ambition. And just say that the report actually shines a light on something that we recognized in WHO in the African region, that our people in the African region and the poorest people suffer worst outcomes from NCDs, including early deaths compared to those in regions with more resources. As you've said, the COVID-19 pandemic is challenging this even more. We already have data indicating that the already serious situation of gaps in access to services in Africa has been further exacerbated by the impact of the pandemic, not only in terms of the overwhelming the health services, but the concerns that people have and the healthcare worker concerns about transmission and risk of being infected if they access healthcare services. So what WHO has been doing already and promoting in a number of countries, the WHO package of essential NCD interventions, or WHOPEN, is being implemented in around 30 countries, which have integrated NCD services, including at the health center level and also going up to the national level. We recognize, and I very much appreciate the comments that have been made by Richard Horton and the panelists and the co-leaders of the Commission, that there is much that needs to be done and the strategy needs to be shifted or expanded to particularly address issues of equity and the poorest people in our countries and globally. As far as the COVID-19 situation is concerned, we've developed guidance in WHO within the framework of the response to the pandemic to address the need to continue to have access to provide access to essential health services, in which we've emphasized the needs for NCDs, because we recognize that the drops in access have been particularly severe as far as NCDs are concerned. So we are promoting and supporting countries to make sure that the triaging of healthcare workers, of patients in healthcare facilities, the provision of PPE to healthcare workers to enable them to be confident to provide services, and most importantly, ensuring that service provision is carried out in such a way that it does not increase the risk of transmission of the virus is carried out. So either through spacing of service delivery or through provision of access to treatment for several months at a time for those who have the fortune to have access to services. I'd just like to say that I very much echo the comments made by Professor Mukumbi at the end, that we need to take the COVID-19 pandemic as an opportunity, that it has so vividly highlighted the importance of inequity in those people that have been particularly affected by the pandemic worldwide, even in the richest countries. And I believe, and we say at WHO, that we're going to take this opportunity of the impact of COVID-19 on financing for health, which is going to be a huge opportunity, to find ways to integrate, have a people-centered approach to providing access to treatment, so that when you think about child health, we don't really think about immunization and treating pneumonias, but you recognize that children are at risk, children are affected by NCDs, the poorest children most seriously, and let's have an essential package of services for the child, starting at the most peripheral level, right up the healthcare system, that incorporates and integrates NCDs. I believe this way we can leverage some of the funding that's available for the diseases that have global health initiatives that are more prioritized by national governments, and that we can, coming out of this disaster of the pandemic, have an approach that really does start to address these inequities. Thank you very much.
Thank you, Dr. Mweti, for sharing what WHO is doing to protect the continuity of care for those suffering from NCDIs. Dr. Nishta, the next question is for you. Has the Special Assistant on Poverty Alleviation and Social Safety to the Prime Minister and Federal Minister of Pakistan, and previous chair of the UN High-Level Commission on NCDs, what are some of the political challenges you have faced in addressing NCDIs and poverty?
Well, thank you very much for that question. Let me at the outset congratulate Jean, Anna, and all the commissioners for the wonderful work, and congratulate Richard for publishing this. In terms of the political challenges, there is a historical context which must be brought to bear. To begin with, NCDs weren't in the framework of the Millennium Development Goals. So for decades, when the world had fiscal space and the appetite to set up programs, there was total neglect of NCDs despite glaring evidence. In fact, there has never been such a wide chasm in public health between knowledge of burden of disease on the one hand and systemic inaction on the other. Also during that era, several chronic disease programs were set up. So all the elements critical for continuity of care were established for HIV and tuberculosis. Essentially, a woman with HIV and AIDS presenting to an African clinic would admirably get the best of care, but a diabetic woman going to the same clinic would not even have access to essential medicines and would be doomed to a life scarred by renal failure, gangrenous toes, and blindness, even though systems were developed to deliver chronic care. So there never was any appetite to accord attention to NCDs. And this lack of attention was not just at the political level, it was also at the technical level because data was shouting at us. And even when there was an emphasis on neglected diseases of poverty, NCDs was missing from the list. Finally, NCDs was included in the SDGs, but the focus, as Jean Buckman very rightly pointed out, was on 4x4. And the limitations of the 4x4 approach is something which Jean has outlined very eloquently. So, unfortunately, there is a systematic resistance to the inclusion of NCDs in universal health coverage, and I experienced it myself when I was co-chairing the WHO High-Level Commission on Non-Communicable Diseases. We were able to push the inclusion of the specific recommendation, and as you know, this was backed by heads of state, but sadly, action has been lagging in this regard. We need to understand that when NCDs are not covered in insurance plans, or when free at the point of service delivery doesn't provide service access or financial access for these diseases, a child with congenital heart disease or rheumatic heart disease is practically doomed. A breadwinner in need of aortic valve replacement is certain to die because they will certainly forego care. There is no level of out-of-pocket payment which is likely to cover these conditions. So in relation to NCDs and poverty, I feel COVID should be a wake-up call for us because NCDs strongly correlate with poverty, and poverty is both a driver and outcome of the epidemic, as the evidence tells us. The challenge now is that the post-COVID fiscal space will be very squeezed. But the good thing is that there will be attention to health systems post-COVID and attention to poverty alleviation and social protection, which provides us with unique windows to integrate the MCD's agenda. I can speak for our government. Even during COVID, we had quite an unprecedented social protection response. And post-COVID, the budgets for social protection have been substantially increased. And that provides us a very unique window to allocate funds for diseases which have an impoverishing effect. So I very much look at this as quite a unique opportunity. And I think that countries can very creatively leverage this opportunity to craft the health system's response to NCDs, which has been lagging for decades.
Thank you, Dr. Nishta, for sharing your experience and your journey in fighting NCDI. Dear Leah, I now turn to you for a question. Non-communicable diseases like sickle cell disease include a broad range of conditions that require unique care. What kind of action can we take to ensure that care is inclusive to the needs of all patients, especially for the most vulnerable?
Thank you, Agnes, and my fellow panelists for this opportunity. And a big congratulations to the commissioners, as well as everyone who had a bit of their efforts in this report. From first glance, I'm seeing it's quite inclusive. So when we are speaking about healthcare for all and for the most vulnerable, we have to understand that this inclusion is to be meaningful, contextual, and relevant to the communities, the countries, and the specific regions we are serving, for strengthening people, policies, and systems that will allow us to close the gap. So with regards to what Anna and Jean said, is that we are losing 800,000 people a year under the age of 40 through NCDIs. And these conditions are not even within the spectrum of the 5x5. So that gives us an inkling of who we need to involve in these conversations. And these people, where are they coming from? Because we are talking about the poorest billion, and we understand that debilitating poverty puts you in a situation where you only are able to look at your basic needs. So how might we empower or prioritize to empower people with regards to capacity and resources and knowledge to lift them out of poverty to a point where they can be able to care and reconcile their situations to a point where, and to a level where they can be able to care for their communities, for justice, and for healthcare, and to bring them to be part of the solution. And lastly, for us who are privileged to have this platform, or privileged to be part of the commission, how do we hold space for those who are not privileged to be here? Inclusion of the most vulnerable is a difficult because we don't know who to involve, where to reach them, what platforms suit them. But having the recognitions that we are a small majority that occupying spaces that only a few are able to occupy, how can we make space or even hold space for those people who are not on the table, pushing agendas that are not only ours, but the agenda for the collective NCDI community to close the gap, because we cannot do this by ourselves. And COVID-19, the beauty about COVID-19 was that it was the ultimate equalizer of all parties. Now we are able to have conversations with people who were never privileged to have the conversations with. So how can we use this opportunity to have conversations that are inclusive for all with regards to closing the gap for the poorest billion? Thank you.
Thank you, Leah, for this interesting and timely reflection. Dear Dr. Moiti, I have a second question for you. How can we tackle the challenges and funds we need to expand services and address NCDIs in the poorest countries?
Yes, again, good question. I mean, first of all, the report really very successfully makes the investment case for governments, and here going beyond ministries of health, very much ministries of finance, the top political leaders, and also to the global development partners on how to work together on an agenda to build the platforms, as Leah was saying, that are needed to strengthen addressing the NCD's impact on the poor, predominantly at younger ages. I also think that the report, the national commissions especially, could link up in terms of advocacy, providing data and evidence that is country specific and therefore could be most persuasive to decision makers about how to incorporate this into some of the work that's already going on. It's already been said that there's been a focus on universal health coverage. We work in WHO, we have quite a few ministers of health and are helping them to update and revise their national universal health coverage, national health policies, strategies, and financing strategies. And we are encouraging them to ensure that these have a strong emphasis on equity, first of all, on making sure that the poorest, most disadvantaged, most vulnerable communities are adequately taken into account in the way that they finance health, in the way that they look for funding for health, primarily to remove that payment out of pocket that so impoverishes people, especially as far as NCDs are concerned. And then at the international level, I believe that the data, the evidence, which is so well presented in the report, should continue to make the case. Even as countries are supported to work on universal health coverage, the needs of NCDs, which have been neglected for so long, need to be particularly taken into account within financing for health in countries and also at the global level. I think that working together of the commissions at the country level, the national NCDIs and the ministries and the other stakeholders who are interested in health, including people who are affected, could really move to change the picture so that at the end of the day, we help the countries to produce financing and service delivery and prevention strategies that are people-centered, that drive integration and leveraging the resources that are available. There is no doubt that additional resources will be needed, and I believe that the case has been made by this report to justify that. Within WHO, I can just add quickly, in line with the 13th General Program of Work that we are going to be implementing in the next 5 years, we've decided in the African region to change our way of working on the so-called vertical programs and shift to a more integrated, people-centered approach, working within health systems in our drive to support countries to work on universal health coverage. And we hope to model some of this, and we'll be very keen to work with the national commissions, with the commission at the global level, in order to learn from some of the experiences of countries like Rwanda and Malawi, and to model our support in such a way that it takes into account this. I believe, as I've already said, that the pandemic and its impact on financing actually is an opportunity. If national leaders, ourselves who provide support and advice on financing, and the international community, if we collectively have the courage to change our way of working, to take into account the needs of the most disadvantaged people, and to realize that the greatest progress in health development and towards the SDGs will happen if we finance with additional resources and we integrate and smartly organize service delivery to address the needs of the underserved poorest billion. Thank you.
Thank you, Dr. Mwiti. And you are right, we have solutions in countries and internationally, and we will succeed if we come together. Dear Dr. Nishta, I have a second question for you. The poorest billion face non-communicable disease that don't always correspond to behavioral risk factors or often disproportionately impact younger patients, such as congenital heart disease or infectious related condition like rheumatic heart disease? Or how can we expand the scope of NCD actions plan to address a more inclusive agenda for those living among the poorest billion that are typically excluded from current plans?
So I'd just like to make 4 very quick points. Firstly, I think at a structural level, WHO needs to broaden its horizon from the 4x4 at the normative level. It needs to internally prioritize NCDs. There's need for catalytic funding to respond to country demands, which is why we called for the creation of a multi-donor trust fund as part of the recommendations of the high-level commission. I think it's absolutely critical that WHO gives it the impetus, and doing that while COVID presents so many challenges is not going to be something easy to turn around. Secondly, there are many opportunities to weave in NCDs in the existing health systems pillars within countries. So there are many population-based surveillance systems, periodic surveys, cyclically conducted, where modules of NCD risk factor surveillance can be integrated. NCD metrics can be integrated in management information systems. There is potential to augment human resource, ongoing training modules, insurance plans can be expanded. We can reorient health systems, especially primary care systems, um, from an orientation towards acute care, uh, more so towards chronic. Most recently, in the wake of COVID, many investments have been made. Laboratory networks have been established. Referral and tracking systems have been created. Task shifting and task sharing approaches have been firmed up. Clinical mentoring mechanisms have been established. The charting tools, databases, so on and so forth. And I believe we can build further on this momentum to reorient health systems towards chronic diseases. Thirdly, at a country level, and as I've also mentioned previously, an unrecognized financing avenue is social protection. I believe it offers great potential, and I think that it needs to be tapped. In my own country, Pakistan, where I have cabinet responsibility for social protection, a child with heart disease, with congenital heart disease, is supported not through the health route, not through the health budgets, but through the social protection routes. So I think this is an approach which can be scaled up and adopted in other countries as well. And fourth, in the fourth place, I think COVID has given us the opportunity and it's emboldened us to think about disruptive policy, about disruptive innovations, and actually go down that route. Just to cite an example from my own country, Pakistan, 160 million people in my country are dependent on daily wages. So within 10 days of the lockdown, the country was at the brink of civil unrest. And my ministry was given $1.25 billion to reach out to practically half of the country with $75 subsistence. And the modalities we developed to reach out to people were totally out of the box. They challenged the business as usual. We would not have been able to do this under normal circumstances. But during COVID, we actually went down this road. We asked people to SMS their identity card numbers, and then we used data analytics to ascertain eligibility and made payments to them, deploying biometric payment systems. So for Pakistan, this was a watershed moment in terms of government functioning, and I think this has changed the way we will run government forever. And we were able to go this far out of the box because of the unusual situation. And I genuinely believe that we can do that for health as well. I genuinely believe that I believe that we can completely transform healthcare and reorient it towards chronic care very soon, within the next couple of years. But the solutions for those transformations do not exist within the ministries of health alone. Today, health systems are being re-engineered in developing countries, not by ministries of health, but by financial institutions and organizations involved in online retailing. And I think that this is a time to reimagine health. I think that NCDs give us a very good peg to embark upon that transformation. And I genuinely think that we need to be bold and transformative in our thinking in order to make those changes that are urgently needed.
Thank you. Thank you. And Leah, remain only 30 seconds. So I'm going to ask you if you can do that in 30 seconds. How has your own experience as a sickle cell patient influenced your work as an advocate looking to influence NCD strategies and interventions? A very important question.
Yes, thank you, Agnes. So if you're living with one of the smaller NCDs, what are called NCDs, you learn very quickly to be an underdog. I have lived with sickle cell for 30 years of my life now, and I live and work in a community with the highest FGM rates, with the lowest education statistics, ranked 5 for HIV, and the other communicable diseases trailing right behind. And NCDs, with regards to diabetes and hypertension, we rank higher than HIV. So when you're coming to approach this community, the plate is already full. So you have to really understand how to be able to maneuver with regards to resources, with regards to making a case for NCDs or for sickle cell. The first thing I've learned is, in the absence of data or money for data, stories make a very good case, or even I think a better case for for non-communicable diseases, especially the smaller disease. And the beauty of sickle cell, not because there is a harshness to sickle cell, but the beauty is that the symptomatic expressions and the complications cut across multiple non-communicable diseases and communicable diseases. The medications we use for management and pain relief come from cancer. I personally have a complication called pulmonary hypertension, which allows me to sit in cardiovascular disease conversations. Retinopathy and leg ulcers fit very well squarely in diabetes conversations. With issues of stroke, we also fit in that kind of conversation. Malaria prophylaxis allows us now to cross the road and enter into communicable disease, and the stigma that is now within our communities for sickle cell and some of the other non-communicable disease was where HIV was a couple of years or decades ago. So how do we mold ourselves, and how are we flexible as a non-communicable disease and injuries community to be able to understand that the communities we're working with are already filled with capacity of the problems that they're trying to resolve? How can we galvanize efforts by looking at intersecting priorities and aligning ourselves to that, because the resources are limited? And how can we be able to not feel threatened if your agenda is not on the table? But I am so happy the commission and the report that they have articulately included these smaller NCDs so beautifully that none of us feels excluded from the table. So for me, with regards to strategies, interventions, and systems, you have to understand how to mold yourself and how to run the race and get your foot in the room for your conversation to be later had. Once they solve everything, they will come to you. Thank you.
Thank you, Leah. So it was a very interesting, thoughtful, provoking conversation through which we deeply explore solutions to finance advocacy and strengthening the capacity of health system. So join me to thank the fantastic panelists who have exchanged with us their ideas, their experience, their expertise, and understand that this is a discussion to be continued, and that we still have a long way ahead of us. Thank you, Dr. Mwiti. Thank you, Dr. Sania. And thank you, Leah. And also, thank you all participants. Back to the moderator for the next segment. And on behalf of all my fellow members of the Commission, again, I congratulate all my fellow members of the Commission. Back to you.
Your Excellencies, delegates, and distinguished guests. On behalf of the Minister of Health of the Federal Democratic Republic of Ethiopia, I'm honored to deliver this message for the global launch of Lancet Non-Communicable Diseases and Injuries Commission report. This launch highlights an important topic neglected for decades and now further challenged by the COVID-19 pandemic. Ethiopia, like most sub-Saharan African countries, has witnessed the increase in the burden of non-communicable diseases and injuries, mainly due to urbanization and sedentary lifestyle changes. Cognizant of these facts, the Ethiopian National NCDI Poverty Commission report has had a national impact by addressing the gap in lack of data and evidence around NCDIs in Ethiopia and in sub-Saharan Africa. It has helped shape the Ministry of Health of Ethiopia's approach towards national planning for NCDs and universal health coverage. Ethiopia has already included the recommendations of the report into the Essential Health Service Package for Ethiopia and into our 5-year health sector transformation strategy. Furthermore, we have blended the NCDI learning module for the health extension program, so our community health workers, who are considered our backbone of healthcare and prevention strategy, provide integrated support to our rural and urban communities. To decentralize NCDI services again to the lower level, we have introduced a comprehensive primary healthcare treatment guideline for our primary healthcare centers. In addition, to enhance our timely response for acute emergencies and injuries, we launched several initiatives such as a major city emergency and critical care improvement to ensure timely care delivery and build a system of resilience. Globally, the government of Ethiopia has advocated for increased investment in NCDIs as part of the goal towards achieving universal health coverage, such as the efforts for the resolution at the 72nd World Health Assembly entitled Emergency Care Systems for Universal Health Coverage, ensuring timely care for the acutely ill and the injured. Despite all our efforts, burden of NCDIs in Ethiopia is rising. Half of the disease burden was due to NCDIs according to the report, which was only 25% 25 years ago. A quarter of all out-of-pocket expenses were for NCDs. Only half of our facilities were ready for NCDs. Additionally, we have seen domestic spending on NCDIs involves disproportionately high out-of-pocket spending compared to spending on other health services. There is still financial gap for NCDIs. We have the evidence that an additional 4.7 per capita could strengthen the highest priority health sector interventions for NCDIs by 2030, thus averting catastrophic health expenditures and ensure attainment of universal health coverage. Investing in NCDIs is not only a health issue, but it's a development issue for poverty alleviation. Today, I call upon all partners and donors to address and prioritize our development agenda through a coordinated global action plan to address NCDIs. Thank you very much.
Thank you all for those compelling insights. I would now like to hand it over to Lancet NCDI Poverty Commissioner, Dr. Yogesh Jain, who will be chairing the second panel that will focus on making universal health coverage fair for the poorest.
Yeah. Thank you for giving me this opportunity to look at the next panel. And first, I would like to, thank the minister from Ethiopia for the insightful comments on the issue about NCDIs among the poor. And I think not only Ethiopia itself, but the other countries would have much to learn from the insights that were presented. Thank you so much again. So I would like to take upon where Richard left and call this a COVID-19 induced syndemic. Where I come from in India, Central India, we have the the matching of COVID-19. We are number 2 at the moment in the world suffering this problem, as well as the rise that we see in large numbers, but also the highest amount of injustice and inequality as a country that any in the world have. So in the context of COVID-19, while there has been a huge demand of the health systems to test and treat those who have COVID, we are seeing from this vantage point, the fragile health systems of the poorer countries of the world breaking down and providing less than acceptable care for COVID. And it is also the COVID, as we know, that has challenged the best resource health centers of the world also. But my biggest worry has been the impact on the non-COVID care functions of the health systems. Whether it's maternal health services, child care, nutrition, immunization, they've all taken a major hit running these programs aground. Similarly, tuberculosis program as an infectious disease has suffered majorly. In Central India, where I work, the new diagnosis rates have plummeted by 50%. And many people are not even returning to collect their refills of medicines, which I think is a very serious thing. But unlike infectious diseases and MCH problems, NCDIs, which our Commission's report brought out graphically, have suffered the most in care programs, since among all groups of diseases, these require well-functioning health systems along with community-based programs the most. And due to lockdowns and redirection of human resources, space, and staff towards COVID, people with diverse NCDs have not been able to continue their treatment, such as maintenance, hemodialysis, refills of medicines for diabetes, mental health problems, epilepsy, hypertension, heart failure, sickle cell diseases have suffered immensely. And I fear that the gains of the last few decades, and not only years of work in understanding and looking after NCDs, may be undone. This is as I see from my work window. So poor are dying more due to NCDs and can't follow the treatment and prevention guidelines, which are highlighting existing inequities. And these need to be removed. So definitely NCDIs in the poorest countries need further investment from bilateral and philanthropic donors, including investments in a service delivery as well as in policy and research. So the funding should focus on the health needs of the poorest billion and should invest strategies that drive health systems improvements. We must integrate NCDIs into universal health coverage and primary health care to have a healthier population. As we know from this Commission's report, that NCDIs account for 60 to 70% of the universal health coverage financing needs in LMICs. I live in a part of central India, which is arguably the epicenter of marginalization and inequality in India, and by implication for the globe. India contributes to the maximum proportion of maximum numbers of the poorest billion in the world. So here, taking the cognizance of the needs of the poorest indigenous communities in central India, while running an effective, comprehensive primary healthcare service, complementing what the state does, we decided to communitize NCD care, shifting the power from a doctor or a hospital to the affected groups of patients. So we created peripheral health facilities manned by non-physician health workers who could provide most of the NCD care, but also facilitate peer support groups for people suffering from NCDs. And we run close to 80 such groups with at least 10 people with a similar disease, who meet once a month, chat about their lives, support each other with information, and improve compliance with drugs and diagnostics, and try to encourage those who are not on treatment to seek treatment, and in fact become advocates for their own illness with the state, asking for treatment close to where they stay, or as an example, asking for disability certification for their illnesses, such as in sickle cell disease. Even these community-based structures have felt very challenged in the recent past, but we realize that their presence has allowed us to avoid the breakdown of treatment continuation that we saw in areas where our peer support groups were not active. And this gives us hope for the future. And this is what I would like to suggest as a solution programs in other similarly low resource areas such as ours. And for discussing some of the questions regarding getting the fair share of support for NCDIs among the poor, I have a panel of 3 distinguished colleagues joining me. Dr. Gitinji Gitahi, who's the CEO of Amref Health Africa. I have Pierella Pachi, who's also she's the person, she's looking after the poverty action in Eastern Africa and Southern Africa, and has been a lead economist with the World Bank in the past. And thirdly, I have Gina, who looks after the type 1 diabetes program at the Hemsley Trust. And I would really like to pick on their brains for their comments on the question that I will pose. And I'll start with a question for Dr. Gitinji Gitahi. Dr. Gitinji, in 2014, in fact 2013, the 80 by 40 by 20 initiative was launched in Africa with the hopes of achieving an 80% reduction in deaths from NCDIs among those who were less than 40 years old and younger living in lower income countries by the year 2020. As a global community, or at least as a global South community, we failed on this agenda, on this initiative. How do you think we can make sure that we don't fail on the NCDI poverty agenda leading into 2030 for a work that you are also one of the co-chairs for that committee?
Thank you very, very much for that question. And I must congratulate the NCDI Commission and Anna and Jean for the excellent performance on this webinar on presenting the summary of the Commission and all the other speakers. Now, Leah, I know Leah very closely, and I know her voice in the advocacy for NCDIs, and I see her voice also feature here. I must congratulate you, Leah, for bringing your voice on this platform. But let me just say that 7 years of my working life was spent on working with cleft lip and palate, which is a congenital condition that affects children, that children are born with. Consistently, we worked in many African countries because I oversaw the African region, and then also what was going on in India. We had a median age of our patients as sometimes as old as 17 years with cleft lip and palate. Especially cleft lip, because for the palate, for many children who did not get early treatment and whose parents could not afford treatment, they died young because they probably had complications of breastfeeding, they had aspiration pneumonia, and all these kind of things. And I'm sure the 800,000 number that is reflected in this commission report includes children who've died of cleft palate as well. Now, what was very strange is that whereas the prevalence rates across the globe were not significantly different, it was 1 in 1,000 births, we never found any of these conditions in Europe and North America. We actually, our colleagues in those countries, we could not find any numbers of people with cleft. Actually, many of my colleagues had never seen somebody with a cleft lip. But when we came to the Global South, it was prevalent. And what actually I learned out of that is that in this NCDI kind of heterogeneous mix of conditions, the main underlying vulnerability is social injustice. It is social injustice that actually excludes people who have certain particular diseases from the larger care. Now, let me reflect on your question as to why we failed. We failed because we did not, for a very long time, we've been fighting about equitable, strong health systems that are based on the people, that build on a primary health care base, that actually do not leave anyone behind. But when you look at even the fights we had in 2019, we were still fighting for universal health coverage, for equitable health access without financial difficulty. That was 2019. So you can imagine 2014 and looking at the 80, 40, 20 to 2019, that's 5 years, still struggling on trying to ensure that people can access the services they need, where they need them without financial difficulty. So moving forward, as you ask about how do we make sure we don't miss the targets on the NCDI. So I want to very quickly, because I know time is short, to reflect on very key areas. Number one, that when we ask about universal health coverage, we look first at several things. How much money do we have? And the question of financial affordability and fiscal space has been reflected on quite a lot, including by Jane. When we know how much we have, and this includes donor, domestic or private money in the country, and also public. In many countries, it is almost 30-30. Government puts in 30, the private people, the household put 30, and donors 30, but it reflects differently in each country. We then ask ourselves, who is in? Which population is in based on our affordability boundaries? Secondly, what is in and what is out? And thirdly, how do we provide this that is in? When we ask the question of what is in, that is where the social justice starts to happen to the people with NCDs, especially those ones that we are talking about now that affect people under 40, things like rheumatic heart disease, sickle cell. And we've had these debates with Leah about when we are creating benefit packages for UHC in Kenya and in other countries, where do we put sickle cell? Where do we put RHD? Where do we put, neuro defects? Now, the question is that whenever we are designing universal health benefit packages, we ask a few questions. And there's a study I was looking at that. What factors do people really consider when they are bringing conditions to be included in the health benefit package of the country? One, and the most important, is cost effectiveness. The country looks through the health technology assessment and says, what is most cost effective? Secondly, where can we actually achieve the most gain? Third, what is the budget impact? And fourth, equity, and fifth, burden of disease. And it is in that order. So when you look at even the UHC, framework of monitoring, we actually, in the NCD section, because out of the 16 tracer indicators, we have actually NCDs there, but they on the 5x5, actually the 4x4 that was reflected on earlier by Jean. So because of this framework of deciding what is critical, what can be afforded, we actually enter only the core that we have actually learned about and we have actually documented. So we need to expand what the health benefit package reflects. We need to actually increase the equity measure The equity measure within the health benefit package formula and criteria is what we need to work on so that we do not fall flat on this agenda like we did for the 80-40-20. So that is something that we need to do, and we can't achieve that without civil society involvement. Thank you.
Thanks. Pierrella, if I may ask you now, as chair of the Poverty and Equity Group of the World Bank, covering both Eastern and Southern Africa, you've been involved in work to eradicate extreme poverty. But how has COVID-19 affected the forecast of achieving these goals and on the burden of health conditions such as NCDIs among the poor?
Thanks very much. First of all, I would like to thank the organizers for inviting me and to congratulate the team on this very interesting and exciting report. And thanks for the question. The finding we have are some very worrying in this regard, and mainly because the swift and very aggressive effort that many African countries have taken to contain the disease were clearly very, very much needed and necessary, but they had really enormous consequences in terms of economic costs. And just to give you some examples, for the first time in 25 years, the region is actually expected to be in recession. What that means is that we expect that in 2020, the GDP per capita across Africa will be 5% lower than it was in 2019. And this is clearly an enormous setback, not just for standard of living generally, but in particular for poverty. People in my team has actually estimated that a reduction of 5%, which is slightly less than what we're actually predicting now, will actually basically set back the progress done on poverty reduction by a decade, by 10 years. We will go back to the level we've seen in 2011. And just to give you some ideas about numbers, 50 million additional Africans are expected to get into poverty. For some of the countries that you work on as part of this project, 1.5 million, in excess actually, 1.6 million more poor will be seen in Ethiopia, more than 2 additional million will be seen in Kenya. This is clearly a major concern for poverty, but there are other important concerns that we're having in terms of health, which is obviously the focus of this event today. We've seen evidence that more mothers and children are beginning to die and will be dying over the next few years from other basically preventable diseases which are not being attended to because of COVID. And this is obviously a major concern, but perhaps the even bigger concern are in terms of the long-term implications of this increase in poverty and lack of income, which has been reported very broadly across all the countries. We know from evidence from previous crises that even very short-term reduction in income for households has very long-term impact on health, on education, and more generally on the welfare of the households. Just to give an example that you are more familiar with than I am, if we look at stunting and the potential for stunting, we expect that this will be increased considerably by a variety of different factors. First of all, the fact that the million of children that have been out of school and will continue to be out of school will not have access to school meals, for example. Second, there is increased evidence of increased pregnancy amongst teenage girls, and we know what that means for stunting and health in later life. But perhaps the most concerning thing is the food security aspects. So we've done some very fast, very sort of high-frequency surveys done with phones in a number of African countries. And we found in Zambia, for example, both in rural and urban Zambia, nearly 1/5 of the households have reported that they're not been able to get access to the main staple food. In Ethiopia, where the situation has been actually comparatively better, but in the first month after the introduction of the shutdown, the incidence of people that couldn't access wheat was really, really high, or increased substantially. So another aspect that I think it's important to notice is the fact that COVID in particular seems to have hit predominantly the urban areas. So while before we calculated as World Bank that only 2 out of 10 poor in Africa lived in urban areas, we expect that with COVID that percentage, that share is increased to at least 3 in 10, if not higher. And of course, we know that non-communicable diseases are actually much more prevalent in urban areas and increases much faster. So what that means is that I think we really need to look at what the implication of this deterioration in economic situation, potential increase in poverty is going to on the incidence of the diseases amongst the poor in Africa, but I think more broadly, globally.
So these are very sobering comments for us. Yeah, but I'll come back to you with another question soon after. But Gina, you as the program manager for type 1 diabetes at the Hemsley Trust, you've been working with one disease, but what are the messages, lessons for us in understanding the work that you do for getting equity at a stage for NCDI works in other diseases, if you may like to talk about.
Thank you, Yorgis. And I would like to also congratulate Jean and Anne and all the commissioners for the hard work that they have done. And also thank Lancet for supporting this work and publishing. At the Helmsley Charitable Trust at the T1D program, our mission is to ensure that people with type 1 diabetes have the right to thrive as any other person on this planet. The Helmsley Type 1 Diabetes Program invests in projects that give the opportunity to people to have access to quality care and to quality interventions and therapeutics. We really focus on bringing the voice of people with type 1 diabetes in the front. And for this reason, 5 years ago, we decided to support the NCDI Poverty Commission. For the poorest billion people, the reality is that access to healthcare and affordable medicines does not guarantee health. There are many other factors in display. Even if a person with type 1 diabetes has access to quality care and drugs, if there is no food on the table, then that means absolutely nothing. I'm sure that this is happening also in other diseases. So I would ask everyone to just think about all the different factors that play in the role of a person with a severe chronic disease. Thank you.
Thanks, Gina, for this very precise and very deep thought out suggestion of yours. Dr. Gitahi, if I may ask you a second question, and I would want a short answer because we are running out of time. NCDI is currently the largest gap in UHC financing, as we know, because it's beyond the poorest countries to cover through their domestic resources. Obviously, given the challenges that COVID poses to the global economic system. As the CEO of AMREF Health Africa, how do you think we can make financing more equitable and distributed in a more integrated way?
Thank you. And as you say, as you request, I'll be very brief. I think the first thing is to look at how the current health expenditure is financed. As I said earlier, most of it, almost 30% in many poor countries, and in some countries like Nigeria is up to 70% by households. So this is one area we need to address. And this area of 70%, as was said by the Minister of Ethiopia, is actually predominantly NCDIs. They're the ones that actually are left out of the country financing strategy significantly. So we need to increase the resources, number one, by increasing public expenditure to the 15% Abuja or to 5% of GDP. Second, increasing donor financing, especially for the poorest countries that can't afford to increase their public expenditure. But the other bit is converting private expenditure by households to social health insurance. And finally, the government using taxes to start with the poorest and actually providing social protection for the poorest, so that then collectively provides a financing framework for NCDIs, but also human-centered for all other bottom-up. That would be my quick response.
Thanks so much. Dr. Pachi, after your sobering comments answers to the first question, how do you believe we can move forward, if at all, in the equity agenda to reconcile the gaps in financing and promote the eradication of poverty, which you have already said is likely to increase at the moment, not eradicate in the near?
So I'm afraid actually I don't have very easy solutions here, and I don't really have a very positive message either. I think the economists are increasingly referring to COVID as the death pandemic. And this is true of both the OECD countries, but also developing countries. And it's particularly concerned, I think, in Africa, where basically we've seen countries that were already verging on the debt, public deficits. So the COVID has just accentuated this, and accentuated for a number of reasons. Accentuated, first of all, because it's clearly reduced the scope for tax revenue. And that's particularly true in countries where a lot of the tax revenue actually come from duties, especially in resource-rich countries, but not others. Second, we've seen that within the revenue that exists, there has been a massive reallocation from basically emergency resources, from things like health and education to actually basically what are called the stimulus packages. In one way, mostly in the middle income countries, and then in social assistance in the African countries. So that's really resulted in the budgets for health and education too to actually shrink. Not only that, but within the health budget, there has actually been basically a diversion, focusing on the budget towards basically COVID-related diseases, which are basically communicable diseases, at the expenses of all the other diseases. So this is going to really reduce even more the amount that African countries, but more generally low-income countries, can actually devote to treating the more chronic type of diseases. What's left is basically the private sector on one hand and donors funding on the others. And we think that private sector funds are also going to be reduced. And I think basically, as the previous speaker was saying, really what we left it was only with the need for having more financing coming from outside to finance this type of interventions. I think the really big issue is really the long-term implications, because at country level, the issue is that basically the cost of this debt is going to be passed on the future generation. And that's going to lead to long-term decline in the resources available for service delivery generally. So in order to avoid the long-term impacts of that, the only real solution we have is to actually sort of focus some of the resources available globally, internationally, on what is going to be left behind by domestic revenue mobilization.
Thanks. So, Gina, if I ask you now, after you've heard Dr. Pachi and Gitinji also speak about their points of view from where they come, how do you think we can leverage the financial strength of philanthropic foundations like yours and strategic partners to focus their attention on a shared agenda for the NCDIs of poverty? Now, I'm not asking you only as a type 1 diabetes program manager, but as a representative of the Hemsley Trust and similar organizations that support healthcare of the poor?
Thank you, Georges. I just wanted to share a very short story. A few years ago and last year, we visited Rwanda, Tanzania, and Malawi. And I had the great pleasure to meet young people who were diagnosed with type 1 diabetes, and most of them they were diagnosed in a nearby Pen Plus site. They all had dreams. They had some of them, they wanted to be healthcare workers, they wanted to become doctors. Another young boy wanted to play music globally and become a DJ. But they all came across the same issues: poverty and lack of education. This is the main message of the Commission's report, that shows actually that what I experienced, you can see it in many other countries globally. To your question, I think, Georges, I strongly believe that philanthropies and other organizations need to break the silos. As you said, I work on type 1 diabetes. Another foundation works on sickle cell anemia, or how to alleviate poverty, or how to improve education. If we do not break the silos, I'm not sure that we can move forward. I'm going to ask every participant to think a bit differently, and how, based on the data that come from the Lancet Commission, how they can help. I'm going to ask them because every data point that is in this report, it is alive. So I'm asking all of you how you can help. How you can help to move away from poverty and to move away from all of the issues that really exist in this world. Thank you.
Yeah, so I started this particular panel not being very hopeful, and I was looking for hope. Amid a sea of of the worries that we have about the pandemic. But and in that sense, I have got hope from from all of you, even though you are being realist also at the same time, and yet be ready to think out of the box. So thank you so much, Kitinji, Pirella, and Gina, for sharing your insights and suggestions that how we move forward to closing the financial gaps for the NCDIs, and look at the increasing risk of poverty that might happen, at least in the sub-Saharan Africa, and to make UHC fairer for the poorest. I would now like to introduce Dr. Jetel Bothweg from the Norwegian Agency for Development Cooperation, NORAD, to highlight Norway's commitment to NCDIs and the importance of it within the framework of UHC.
My thanks go to the Lancet and the organising committee for inviting me to take part in the launch of the Lancet Commission report on reframing NCDs and injuries for the poorest billion, and to our hosts. Congratulations on launching the report. This Lancet report on NCDs among the poor is a very significant contribution to the debate. It highlights the issues when dealing with the prevention and control of NCDs in the global development agenda. As you may know, Norway, as the first country in the world, launched an NCD strategy in the context of development aid in November last year. Now is a very exciting time for us as we are moving towards operationalizing the strategy. These days, the world is fighting COVID-19, which is a communicable disease. However, there are strong links to the non-communicable diseases, since people living with NCDs, such as cardiovascular diseases, diabetes, and cancer, are at risk for getting sick and die from COVID-19. And the measures implemented to curtail the pandemic has also had unintended mental health consequences due to isolation and to fear. A lot of work went into doing the preliminary policy analysis for the strategy, and NORAD was charged with drawing up an analysis of the issues. One of the sources we consulted were the, as of then, unpublished material contained in the report that is launched today. It made us think, it challenged us, and it informed our analysis. One of the most important points in our strategy is to consider equitable provision of basic services and prevention of risk factors together. The key point here is universal health coverage and primary health care, meaning access to a set of essential healthcare services that does not subject anyone to financial hardship. Now, health is a political choice, and inequities in health are built into the very foundations of our societies. Both social and commercial determinants of health shape not only access to and the use of services, but also the pattern of the underlying risks themselves. Risk factors for NCDs, such as tobacco and harmful alcohol use, consumption of certain foods, and exposure to air pollution, are influenced by underlying policy choices. Since these inequities are the results of political choices, they can also be changed. NCDs in low-income countries will represent a significant future strain on health systems and family and public budgets. It's imperative that we future-proof health systems for this challenge. In conclusion, let me congratulate you again on publishing this timely report. Thank you and good luck.
Thank you so much to everyone who participated in this event. One remarkable thing about NCDIs that we recognized in the course of working on this report is their incredible diversity in terms of severity. We have learned this from the mental health community, which recognizes the special care we owe to those with terrible conditions such as schizophrenia, for example, especially when they affect those also living in extreme material poverty. Our final speaker also reminds us of this fact, and it's an honor to introduce her as our closing speaker, Dr. Nalhana Khumalo. Dr. Khumalo is professor and head of the Division of Dermatology at the Groote Schuur Hospital at the University of Cape Town in South Africa. She's also the wife of Bongani Mayosi, who is so important to this commission and whom we hope would be proud of the work that we have accomplished here today. Thank you.
Good morning, everyone. Thank you to the Lancet and commissioners of the latest NCDI Poverty Report for this kind invitation. Congratulations on successfully shining the spotlight on the neglected bottom million. And thank you for honoring Bongani Mayosi, who used that phrase so often he may have coined it. He worked tirelessly to mobilize the world to care and make a difference. Thank you also for the opportunity to briefly mention dermatology, a discipline that largely suffers from various myths, including that it is a cosmetic discipline and that no one dies. However, severe and life-threatening conditions, especially in the autoimmune and malignant spectrum of diseases, often presents with skin lesions. Even excluding the large burden of infectious diseases, inflammatory diseases such as psoriasis, which has a lifetime prevalence of 1%, are common and can severely affect quality of life. Atopic eczema, which is incessantly itchy, uncomfortable with sleepless nights, has a prevalence which rises up to 19.4% from 2.9%, depending on which region in the world you're looking at. And this slide is courtesy of Carol Schreller, one of Bongani's many mentees, who is now head of pediatric dermatology at Red Cross Children's Hospital. I will end by sharing a slide of Bongani talking at a conference as a 20-year-old medical student in 1987. He had a passion for excellence that started very early in his life, a voracious appetite for reading and knowledge, a humble brilliance uncommon among academics, an exemplary love for family and humanity. And as he always used to say, lift as you rise. May we also lift as we rise and better the world. Thank you and congratulations.
I hope you have found today's global event as captivating, inspiring, and activating as I have. I want to thank all of our guests for sharing your invaluable perspectives and experience with us. And I really want to thank all of our viewers for joining us today and joining us in this critical moment in movement for the poorest billion people suffering from NCDIs. I hope that today's conversation is just the beginning, and I hope that you will join the NCDI Poverty Network to help address the great inequalities that persist in NCDI prevention and care. Thank you all very much.